I'm honored and I have a pleasure to host today our first international guest, this seminar for philosophy and psychiatry. And this is Dr. Roy Dings. And he's currently a postdoctoral researcher at the Radboud University, where he obtained his PhD in 2020. Before that, he was a postdoctoral researcher at the University of Memphis and Bochum University, as I recall. So his research is mostly at the intersection of philosophy, psychology, and psychiatry. And he works on themes like self-illness ambiguity and experiential knowledge in the mental health care. This is something that we will talk about, that he will talk about today, and different other topics. So, Roy, take it away. It's your time.
Okay, thank you. Yes, thanks also for the invitation to present my research here. So the topic is, in the title, is quite broad. So it's lived experience, knowledge, and expertise in mental health care. And I think the sort of central term that I will be talking about is the idea of experiential knowledge. So that's the idea that people who have experienced, for instance, depression or autism firsthand, that those people have a unique epistemic perspective, namely that they have something like experiential knowledge, and that can be put to use in mental health care. So the problem basically, or the main reason why I'm interested in this topic from a philosophical perspective, is because there have been a lot of worries about the concept of experiential knowledge being, very simply put, sorry?
No, everything's okay.
Okay, sure. So the worry is that this concept is relatively vague. And so this is actually also what you see in some recent review articles, right? So here on the left, by Castro and colleagues who say that although the concept of experiential expertise is relatively new, the absence of theoretical and conceptual clarity has led to poor understanding and miscommunication among researchers, health practitioners, and policymakers. And Halloy and colleagues go even a step further, you could say, when they claim that despite popular and institutional success, the concept of experiential knowledge remains loosely defined, with the result of weakening its heuristic scope and paving the way for its commodification. The term experiential knowledge, as it is currently used, is a polysemous catch-all concept that applies to myriad definitions. In the scientific literature, the concept is rarely defined explicitly or is solely evoked in a broad and imprecise way as knowledge derived from patient experiences. So my evaluation of this trend, and so I'm from the Netherlands, and here it really is a trend in the sense that almost all mental health care institutions employ experiential experts. They are a central aspect of policy making, for instance. So it's a very common thing these days, and it's increasingly common as well. But the worry here seems to be that, like I said, there is a kind of intuition that if you've experienced mental illness firsthand, that offers knowledge. However, it seems that we're kind of stuck on this level of intuitions, right? And that's also what I take these quotes on the screen to show, that it's an interesting and fascinating concept, but in itself it's quite vague in the sense that it kind of sticks to this intuition, but nothing beyond that. And I think that what I'm trying to do as a philosopher is I'm trying to explain a little bit more about what experiential knowledge might be. And so the interesting thing, I think, is that this is a bit problematic, but I think many philosophers have fallen prey to this as well, in the sense that philosophers, almost by definition, are people who would be very careful in the concepts that they use, but I feel like philosophers actually have failed to elaborate on what they mean by experiential knowledge. So, for instance, there has been a lot of research on epistemic injustice in psychiatry, many of which is written by philosophers. And of course, I don't have room here to discuss all of this research in detail, but I just want to pinpoint that the concept of epistemic injustice holds that someone is not taken seriously as a knower, as someone who possesses knowledge. And I feel that when it comes to the context of mental health care, an open question still is what patients or former patients, what type of knowledge they actually have. And presumably it is something like experiential knowledge. But again, as the earlier quotes show, that is not very precise. That is still on the levels of just intuitions. And I feel that this is something that has to be addressed. So at this point, I should make a very important disclaimer, which is that we can distinguish between, let's say, an epistemic and a more political ethical motivation for including former service users. So why would mental health care employ people who have experienced, let's say, depression and have recovered from that? So the political ethical motivation is something along the lines of, the famous slogan, "Nothing about us without us," for instance, illustrates this idea that if you make policy for a specific population, then you need to include that population in the making of policy, for instance, as well. Now, the epistemic motivation, of course, is the idea that including them adds something in terms of knowledge, that they have a unique form of knowledge that nobody else is able to access. And so including former service users strengthens our epistemic investigation of mental illness and treatments, etc. Now, we can also make an analogous distinction between the function that these service users have in mental health care. So some of the contributions of people who call themselves experts by experience, some contributions could be labeled epistemic and other could be labeled as non-epistemic. So the epistemic contributions would be contributions in which a claim to knowledge is being made. So if you say that, policy should be like this rather than that, then you make a claim of knowledge. And if you say that with individual peer support or recovery support, for instance, if you say that, taking a certain hobby or saying something about the role of social contexts in recovery, that's an epistemic contribution, because you're making a claim of knowledge. You're claiming to know that something works better than something else. Now, a lot of the contributions that service users make are actually non-epistemic contributions, so where they're not making a claim to knowledge. So the prime examples here are that they serve as a role model, or that they provide hope, that they are empowering to fellow patients, etc. So they're not making any claims to knowledge, they're just offering hope. And now the point that I want to make is that even if we would conclude that there actually is not any epistemic contribution that they have, so even if, hypothetically speaking, experiential knowledge turns to be something that doesn't really exist, then still it would be worthwhile to include former service users in mental health care, if only for the non-epistemic contributions, which in themselves are already extremely valuable. That being said, I do think that there is a unique epistemic contribution. So I do think that there is something like experiential knowledge that you can only gain by experience, and that is difficult to access, or impossible even to access for other people. But this hasn't been elaborated yet, but I will at the end of this talk. So what I want to do in the rest of this presentation is basically two things, two nutshell summaries, if you will. So what I'll be presenting is quite dense. So feel free to ask me about any of these topics in the Q&A, and we can discuss further. So the two nutshells pertain to what I would call the negative project, or the project of explicating what is wrong with current views on experiential knowledge and expertise. In other words, if you look at current research on experiential knowledge, what is problematic about it from a philosophical perspective? And this is something that I've been doing these past couple of years. So there's already some published work on this. If you're interested in it, I will add the references in the slides, and also feel free to contact me afterwards to if you cannot access the papers yourself. And after that, I will turn to what you could call the positive project. So actually developing an account of experiential knowledge and expertise that is conceptually, epistemologically, and phenomenologically sound. Now, this is still a work in progress, so it's a paper that I'm still writing, but it's not finished. So, you know, I would appreciate feedback on this as well. Okay. So starting with the so-called negative project. So the first question that we can ask is, if we have something like experiential knowledge, then what kind of experience would form the basis for that? What kind of experience is at stake when we talk about experiential knowledge? And surprisingly, this type of question really hasn't been asked by people who work on this topic, right? So they kind of just assume that experience is something that is given, right? That is simple, homogeneous, that it makes, you know, that everyone understands what this means, etc. And of course, from a philosophical perspective, we can question that, because experience is much more complex and heterogeneous than we might assume. So in one paper that I wrote with Sarif Takin, published in Philosophical Psychology, we have this kind of thought experiment that we that is based on an analogy with this famous thought experiment by Frank Jackson. So Frank Jackson, in his knowledge argument, asks us to imagine a woman, Mary, who is he visualized here. So Mary grows up in a black and white room, and so she can only see different shades of gray. And then during her life, she becomes an expert on color vision. So she learns everything there is to know about color vision, right? So she knows exactly what kind of wavelength of light, you know, the way that it enters the retina, the way that it's processed in the brain, the way that it leads to an experience that people would label as red, for instance. And then the main point in the thought experiment is that when she leaves the black and white room, whether she then learns something new. Because the idea was that she has learned everything there is to learn from, you know, books and science, etc. And then does she learn something new when she leaves the black and white room and for the first time she sees red, the color red herself? And then this has sparked a really ridiculous amount of philosophical work. And most of that seems to converge on the idea that she does learn something new, namely what it is like to experience red. So she already knew all facts about perceiving the color red, but now she has learned what it is like to experience the color red. And so in the paper, we make this analogy with, I think we call her Sarah. So imagine Sarah, who is a scientist and a clinician who is an expert on depression. So she knows everything about the genetic underpinnings of depression. She knows exactly what the role of development and social pressures is. She knows exactly what kind of treatments work, etc. And then again, you know, at some point she herself becomes depressed. And now the question is, has she learned something new? And again, I think that a lot of people would agree that she learned something new. And if you would ask them what that is, then people might say something along the lines of that she has now learned what it is like to be depressed. Now, the thing is that this what it is likeness is something that philosophers have tended to see as a unique element of experience, which they would call phenomenal experience. And so in this paper with Takin, we investigated, well, is experiential knowledge something that has to do with phenomenal experience or maybe something else? And we conclude that it's basically not clear. So some work seems to be about phenomenal experience, but then other work on experiential knowledge seems to be about a more common everyday type of experience. Like when you would say, I have a lot of experience teaching, then you probably don't mean the kind of phenomenal experience of teaching, but something more colloquial. And then what we say in the paper is that, either way, there's problems. So if it's the phenomenal aspects of experience that are at stake, then there's problems. And if it's not the phenomenal aspects of experience, then there's problems as well. So here I want to just briefly mention two of those problems. One is reification. So reification is the tendency to assume that there is a thing, an entity underlying concepts and everyday words. So the reason why this is relevant is because a lot of the field of experiential knowledge is based on things like DSM classifications. So people would say, I have experiential knowledge with respect to autism, or I have experiential knowledge with respect to depression. But the point is that you cannot experience depression and you cannot experience autism. And this sounds a bit odd, but the point here is that autism and depression by themselves are categories, they're classifications. So the things that you experience are the symptoms, right, which form the basis for the diagnosis of the classification. And now if we acknowledge that, then something interesting happens, because even though not everyone has a diagnosis of autism and not everyone has a diagnosis of depression, most people would have experienced some of the individual symptoms, right? So in the case of depression, one symptom is disruptions in your eating and sleeping cycle. And most people have experienced that. Pervasive sadness. I mean, most people, even in the context of grief, have experienced that. Same for autism. So even though not everyone has a diagnosis of autism, most people have experienced things like struggles with social contexts. Most people have experienced being overwhelmed by stimuli, etc. So even though we don't want to say that this would mean that everyone has experiential knowledge with respect to autism, we do think that it hints at a much more gradual idea of experiential knowledge as how it is commonly assumed. So the second point here, or well, it's actually the third on the list, has to do with diversity and heterogeneity. So the point here is fairly simple, namely, people are diverse and illnesses are diverse as well, right? So given that diagnoses are based on clusters of symptoms, there's different combinations possible. So you could have 10 people who are all diagnosed with depression, but who have very different experiences. So to just give a simple example, it's probably different. The experience of autism is probably different for a young male compared to an old female, for instance. And it's probably also different for someone in the United States compared to someone in Japan. So the idea here is that it's not that they all have the same experience. So experiential knowledge of depression, for instance, doesn't really make sense, because 10 people who are depressed have 10 very different experiences. And the point here is that this heterogeneity is typically not acknowledged in the way that people think about experiential knowledge. So another thing that I want to highlight, because it's very fascinating from a philosophical perspective, is the fact that the field of experiential knowledge focuses both on narrative as well as on embodiment, but those two seem to be at odds with one another. So the point here is that if you want to become an expert by experience, then one of the main requirements here is that you create a narrative, a self-narrative about the journey of recovery that you've undergone. You have to sort of make connections between, let's say, the moment that you were diagnosed up until the moment where you truly felt recovered, etc. You have to make connections to something like your early development, the role that your friends and family plate, for instance. But on the other hand, there is a lot of emphasis on embodiment. So embodiment mainly plays a role in the sense that it's typically seen as something that is crucial to lived experience. So what it is like for someone to be depressed is inextricable from the way that their body feels during their depression. But the point here is that creating a narrative of that abstracts away from it. So embodiment seems to be crucial to making it such that the person who has the experience is also the person who creates experiential knowledge. But then the focus on narrative seems to be in tension with that. Because if you put it into language, then the knowledge that you possess switches from something that is embodied to something that is linguistically mediated, and that can be as such easily transferred. A second problem here is, of course, the fact that narration, by definition, includes various processes of reconstruction, both in experience and in memory. So narrating an experience means selecting certain parts of the experience, emphasizing certain points, leaving out certain elements of the experience, etc. In other words, a narrative of your depression or a narrative of your process of recovery is very likely to not actually reflect the experience of depression or the experience of recovery. It's a narrative, it's a reconstruction. So this too puts pressure on the idea that the experience itself is really crucial for someone to have experiential knowledge. Okay, so moving on to the last bit of the negative project, so to speak, is questions about knowledge. And again, it's really fascinating to me why these types of questions are not asked more often. So what sort of knowledge is experiential knowledge, and who possesses that knowledge? So if you look at the literature, you see that, I mean, I would say maybe 70% of the research just doesn't really say anything about this. And then the remaining 30% has a sort of generic answer. So they say experiential knowledge is tacit knowledge or it's practical knowledge. But the point is that that should be the starting point for investigating experiential knowledge. It shouldn't be the end point, right? Identifying it as practical knowledge is not very informative. So the interesting development that has happened in recent years, and that's why I added this figure here, is the idea that experiential knowledge is something that, of course, starts with an individual. So someone experiences a psychosis or has bipolar disease, and then recovers from that, and then creates a narrative of that, reflects on that. But then if that person shares their experience with other people who may have also experienced autism or who has also been mentally ill, then the exchange of that knowledge strengthens it. And so over time, you get something that people would call collective experiential knowledge or deep experiential knowledge, where through this process of sharing and collectivizing, you would see certain patterns, right? So you would see, well, all of these people who have struggled with depression, they all have this and this and this, for instance. And then you have a kind of knowledge that is no longer idiosyncratic, but it's more general. Now, the main worry here, I'm not sure to what extent this is obvious, but the main worry here is how this differs from qualitative research. So if you look at social science, but also, for instance, phenomenology, so I'll take the work of Matthew Radcliffe here as an example. What they do is, to a large extent, the same thing, right? So they ask a significant amount of people. I think actually in this study by Matthew Radcliffe, it was via an internet questionnaire where people could submit their experiences. And what they do is they collect a lot of experiences, and then they try to find patterns in those experiences. Now, the main difference, of course, is that people like Radcliffe or social scientists more generally have certain methods that they use. They're trained in doing this, they're trained in avoiding bias, etc. Whereas if you would just have lay people, so people who don't have any training in doing research, if you have them, sharing these stories and trying to find patterns in them, I think it's very more likely that you encounter biases or other kinds of methodological obstacles. Okay, so all of that was negative, right? So that was sort of criticizing contemporary ideas and research in the field of experiential knowledge. So what I want to do in the remainder of this talk, so this is just going to be a few slides, is to say something about what I think experiential knowledge is. So in other words, I'm going to try to say something about how I think what I think is a worthwhile conceptualization of this idea of experiential knowledge in a way that it safeguards the fact that someone with experience does have a unique epistemic contribution, but also in a way that it kind of sidesteps some of the worries that I've outlined in the previous slides. So I think the core of this idea that I have is that we should construe experiential knowledge as a form of responsiveness. And responsiveness is a very interesting notion because it's at the same time extremely trivial, but it's also super important in our everyday agency and the way that we think and act and feel. So let me say a little bit more about that. So it's trivial in the sense that it really has to do with this very basic way in which we experience the world. So if you're responsive to something, that means that you notice it, that you feel something. So someone with a particular style of responsiveness experiences some things as relevant, others as irrelevant, some things as meaningful, others are as non-meaningful. Being responsive means processing information in a certain way, being affected by the world in a certain way, and it very much mimics the phenomenological idea of a life world. So the crucial thing here is that it changes through experience, right? So in everyday life, the experiences that we have change what we are responsive to. So if I'm hungry, then I'm responsive to food. But if I've already eaten, then this responsiveness to food decreases, right? So a sandwich that I see is very I'm very responsive to a sandwich if I'm hungry, but I really don't care about sandwiches if I'm already full. So that's the trivial bit, but this also works for the more substantial experiences of, let's say, depression or psychosis. So in the thought experiment that I mentioned earlier about someone who is an expert on depression and then becomes depressed herself, what does this person learn? Well, the thing is that I'm not sure if it's best construed as knowledge, but I would construe this in terms of a change in her responsiveness. So because she has experienced depression, she has now become responsive to different things in the world, or she has the existing responsiveness that she already had has started to become more subtle. The meaning that she associates with things is different, etc. So there's two other elements that I want to highlight. One is that pertains to the role of language. So actually, I think that language really hinges on this notion of responsiveness. So imagine that there's three people who are having a discussion on hallucinations, or let's say having an LSD trip. Now, 2 out of 3 have taken LSD and have experienced such an LSD trip themselves, and the third person hasn't. Now, what you'll see is that the 2 people who have experienced an LSD trip are able to communicate about this quite easily, whereas the third person doesn't really know what they're talking about, right? This is maybe again, this goes not only for these kind of clinical cases, but also for everyday cases, right? So I'm not sure who in the audience has children, but if you have a group of people and some of them have children and others don't, then the people who have children are able to communicate about the difficulties of having children quite easily. Whereas the people who don't have children, they try to sort of make sense of that by using analogous experiences, but they usually fail to a certain extent. Now, I think that the reason why that communication works in some cases, but not in others. So the reason why it works in cases when people have similar experiences is because those experiences have changed their responsiveness. So if you talk about an LSD trip, then it's very likely that you're using kind of metaphorical language. And the only way in which you're able to convey the stuff that you're trying to convey with that metaphor is if the other person is appropriately responsive to that metaphor, right? So the metaphor only works if the people who you're talking to are responsive to that metaphor. And the point is that people who have had the similar experience are responsive, and people without the experience are not. Now, another point that I want to add to this is that it's also thoroughly embodied. So this idea of responsiveness also has to do with being responsive in a bodily way. So your body responds to the stuff in the environment, for instance. And in previous work, I've tried to cash that out in terms of affordances. So I'm not sure if everyone is familiar with this idea, but the rough sketch is that affordances are possibilities for action in the environment. So a chair affords sitting on, for instance, and standing on. An extended hand affords shaking. And so the idea is that what happens in mental illness is that your perception of affordances changes. And one crucial element within your perception of affordances is your responsiveness to those affordances. So this picture that I have here with the various graphs is from a study by Sanakarahan and colleagues who investigated the impact of a certain neurosurgical treatment on mental illness. So the idea of this graph is that each bar that you see represents an action possibility. And in a normal non-pathological case, so hopefully that goes for most of us, the way that you would experience the world around you, the way that you're responsive to the possibilities for action around you is quite diverse, right? Some things are attractive, others are not. Some things are sort of very proximal, others are more distal, etc. And so what happens in the case of depression is that people are not responsive to any action possibility. And what happens in OCD is that they're only responsive to a very specific action possibility, for instance. Okay, so this is the last slide. So one of the main points that I made previously is this idea that experiences are diverse, right? So so I said what it is like for someone to experience autism is probably different for a 20-year-old man compared to a 30-year-old woman. Same for someone from a Western culture compared to someone from a non-Western culture, etc. But I've also said in the previous slide that all experiences affect your responsiveness. So everyone has a particular responsiveness profile, if you will. Now, what people who work as experiential experts in mental health care do, I think, is best captured by something that I would like to call attuned responsiveness. So what you have to do is to be responsive to someone else's responsiveness. That's basically what attunement here means. And one of the main ways of cashing this out is, again, by using this idea from Matthew Radcliffe, who in a 2012 paper wrote about what he calls radical empathy. So the question he poses is whether we can understand, really grasp the way that someone with mental illness experiences the world. And according to Radcliffe, we can. So he says that the way that we experience the world has to do with experiences of significance, right? Kind of in line with the stuff that I've been saying about responsiveness. So the world as we experience it is a world where some things are relevant, others are not, some things are significant, others are not, etc. And for most people, you know, we have a shared world. The way that you and I experience the world is probably shared to a large extent. But the point is that in the case of someone with mental illness, we need to bracket some of that shared world, right? So we cannot take for granted that someone else experiences the same kinds of significance that I experience. In other words, we have to bracket the fact that someone else might not be responsive in the same way as I am to the world. And so Radcliffe says that this not only goes for trying to understand someone else with a mental illness, but also when you engage with someone from a completely different culture, right? They will also probably not be responsive to the same things you are. And then he also gives the example of children. And that's why I have this picture here. So this is a picture of me and my daughter doing the dishes. And so the idea is that if you're doing the dishes, then as an adult, you know that there might be like knives in the water, right? So sharp things. So the way that you're responsive to the water is in a certain way. You know that you shouldn't put your hands in the water too quickly. You have to kind of, you know, put them in the water gently and then calmly pick up one of the knives in the water, for instance, in order for it to be washed. Now, my daughter, who is 2 years old on this picture, she probably doesn't know about the fact that there is knives in the water, that they're sharp, that you can cut yourself with them, etc. So as a father, I'm trying to attune my responsiveness to hers. She is not responsive to the knives in an appropriate way. So I have to sort of try to experience the world through her eyes, so to speak. I have to make sure that her way of experiencing the world is compatible in a way that she's not able to hurt herself, right? So I might take out the knives out of the water before let her help. I might warn her and say, you know, you can help me, but you can only help by, I don't know, putting the stuff that we already washed away instead of putting your hands in the water, etc. There's a different way of cashing this out, which is in terms of what phenomenologists would call pre-understanding. So the idea is quite similar, namely that even if there is some element of experience where you differ, which is probably the case when it comes to mental illness, right? So someone with a psychosis or a history of psychosis has a radically different way of experiencing the world compared to someone who doesn't experience psychosis. At the same time, however, there is an enormous amount of experience that is shared, right? So let's say that they're both, they're both embodied in roughly the same way. And even if it's a man versus a woman, there are differences there, but there's also an enormous overlap. I mean, we both have to breathe in order to survive. We both have to eat in order to survive, etc. It's very likely that you both grew up in the same kind of culture. You might be roughly the same age. And so the idea is that all of those things create a kind of common ground, a common form of responsiveness that you can build on in this process of attunement. So I think this attunement, this being able to adapt your own responsiveness to someone else's, is really a crucial skill for someone who works as an experiential expert. And I would even say that this is the main skill that would have to be trained for someone who is engaged in a process of becoming an experiential expert. Okay, so thank you for your attention. If you want to get in touch about this stuff, please don't hesitate. So I'm trying to set up a network of people who work on this or related topics and have them exchange ideas. I've listed some paper, don't mind hesitate to get in touch. And I'm looking forward to any questions that you might have.
Okay, great. Thank you. This was wonderful. I will take the questions from people here at the Institute or anyone who's online. So please do ask anything or any clarifications if you need. So we have a question here from one of our guests at the Institute, Stefan. He's a psychiatrist, so I think he'll have a very practical questions, but also very interesting theoretical questions.
Thank you very much for a really excellent and thought-provoking talk. So, as Janko says, I'm a practitioner with interest relating to these issues, and I have several questions that pertain mostly to the negative part of your talk. So, and maybe I missed something, so please correct me. So, at one point you said how we can, if we base ourselves, our experience on symptoms of depression and not on the category of depression, so then we can, even if people who are not depressed, sometimes we have these overlapping experiences and we can experientially see what it's like for someone to be depressed, if I understood you correctly. So I'm wondering, how would you defend this argument with regards to the phenomenological literature and first-person reports which say that in depression there is something, in depressive mood specifically, there is something which is qualitatively different than sadness, which we see as a regular part of life. So this is the first question. Do you want me to ask several of them or take this one?
I think I would prefer to address them one by one, if that's okay with you.
Yeah, of course.
So that's a very interesting question. Thanks. So I think there's different answers to this. So the first answer would be to say that, let's say, a full-blown depression, so someone who is actually diagnosed with depression, they have a significant amount of symptoms, right? So it's not only the disruption of the sleeping and eating cycle, it's not only the feelings of shame, it's not only the pervasive sadness, but it's all of that in combination for a significant period of time. So one way to answer your question would be to say, well, what the phenomenologists are investigating is precisely that. So if you have experienced all of those symptoms in combination for a significant period of time, that's what makes it unique. But again, I would hold that, so the claim I think would still be the same, namely that even though that doesn't mean that someone who has experienced a lot of experiences of shame or disruptions in the way that they eat, that doesn't mean that they know what it is like to be depressed. But it does open the door for the dialogue about their experiences, because the thing is that I've often seen also in a personal context. So I have a brother-in-law with autism, right? So he would say, "You don't know what it's like, so you cannot say anything about this." And I think that's not true. I mean, all of us have experiences where we struggle with things, and I think it's better to use those as a way of having a meaningful discussion instead of saying, well, but I'm in this unique position and you cannot in any way access that, so there is no discussion possible. Now, that being said, I do think that there is also the more controversial option of answering your question in terms of, so you asked me that I should prove or that I would have to defend why those phenomenologists come up with this idea that there is a unique quality. And a part of me wants to say, well, maybe it should be the other way around, right? So, so maybe as a little bit of self-disclosure, so I've also struggled with depression myself. And I'm still not sure whether there was really something qualitatively different than earlier episodes in my life where I also struggled with things. I mean, obviously it was much more intense and it was much more related to different elements of my life. But I'm not, yeah. I mean, yeah. So it could be that I wasn't sufficiently depressed, so to speak, and that the people who are discussed in those phenomenological reports are, more severe cases. That could be. So yeah, I'm not sure. But the point that I want to make here today in this talk is only to say that I think it's much more useful to think of experiential knowledge as something that is more gradual rather than something that is an all or nothing phenomenon. Because it helps us to create a more meaningful dialogue between people because it provides common ground.
Yeah, it's a great answer. Thank you very much. So I also wanted to ask you, you also said in the negative part that experience is somehow more important than the narrative, if I understood you correctly. And, or at least that I'm wondering, why do you think that is? Because as we, and I might be wrong with this, but psychotherapy usually works on the narrative, and this is a demonstrated treatment option. So basically, for people who have, for example, depression or anxiety disorder or any other, let's say, DSM diagnosis, usually the procedure is such that it's important which specific experience you have, but maybe less important than what your narrative is about. So, do you have any comments on that? Why would the narrative be, let's say, second-hand to the experience?
No. So I think that the point here is that so the thing is that gives rise to a dilemma, and the dilemma is something that I hope to have sort of resolved by means of the positive account. But the dilemma is this: if you put a lot of emphasis on narrative, that means that you put a lot of emphasis on something that you can put into words, that you can exchange with other people. So then the question is, well, why then should the person who has had the experience be the person who works as an expert by experience? Why not have a researcher collect all of those narratives and find the patterns? And I think that this is/was an open question, because the experience is meant to safeguard the role of the person who's had the experience, obviously. And I think with the emphasis on narratives, you kind of put that into, it becomes problematic because a narrative can be conveyed and an embodied experience cannot. Now, I hope my account of, so the positive account of responsiveness shows or kind of attempts to resolve that tension, namely that a narrative can only be conveyed appropriately, right? So to people who are responsive in the right way. And again, those are people who've had the experience. So, so if Matthew Radcliffe tries to collect all of the pattern, all of the accounts, all of the testimonies of people with depression, and tries to find patterns in those, then the reason why he might be less successful or less good at doing that than someone who has himself struggled with depression is because Matthew Radcliffe approaches those testimonies more or less objectively with his own responsiveness, which is not necessarily the kind of responsiveness that is most optimal there. And to be honest, I'm not sure. I actually think that Matthew Radcliffe has also struggled with depression, so the example might not work in that respect. And actually, that allows me to make a sort of follow-up point, which is that I've talked about people with experiential knowledge and, for instance, researchers or clinicians as being opposite. But of course, I think there's enormous value in the fact that people who work in mental health care themselves often also have had experiences of either mental illness, or they might have had family members or relatives with mental illness. And, by those experiences also learn a lot that they can use in practice, and oftentimes they already do use that in practice. And here in the Netherlands, this is something that clinicians in training are also educated in. So how can you use experiences that you've had yourself in a functional manner, in a way that it actually benefits the treatment or the relationship with the patient, for instance?
Yeah, thank you very much. And just a quick follow-up to that, relating to practitioners, people who work with people, other people in mental health care, who themselves have lived experience. So would you say that it's always a good thing for someone who works with other people to have the experience of this notion of the wounded healer, that it's always a benefit? And if you do agree, would you say that we should have like policies which connect people who have had lived experience and who are practitioners, that they should work with other people? For example, a psychiatrist or a psychologist who is depressed, who had depression at some point in his life, should always work with other people who have had similar experiences.
So I would definitely not want to make any general claims. So I wouldn't want to say that, all of them would have to do that, or that it's always better or something like that. I would refrain from any of those claims. I do think it's worthwhile to explore what benefits it could have. And so what we see in the Netherlands is that that professions in, let's say, the lower part of the treatment hierarchy, so nurses and social workers, they are more often motivated to use their own experience, whereas psychologists and psychiatrists are more hesitant in doing that. And there's obviously reasons for why it's good to be hesitant in some cases, right? So it seems that there has to be a sort of good division of labor in any treatment. So the kind of knowledge that is used by a psychiatrist, is, sometimes it's just medical knowledge that they use. Other times it's more clinical or kind of scientific knowledge. And now the question is whether they could also sometimes rely on experiential knowledge. And I think that the answer is yes, they might sometimes use that, but being able to do it well is really a skill. So I wouldn't want any like novel clinician, someone who just started working as a clinician. I would say, don't rely on your own experiences too much. But someone who has years of experience, they might be in a better position to find a balance in doing that.
Yeah, thank you very much.
Okay, thank you, Stefan. There is a question from one of the people from the chat. So I'll just read it to you. So Lily Clark said, or has a couple of questions. Here it is. If language restricts transference of experience, narrative construction that is, how do we avoid the similar in accessing experiential knowledge as a responsiveness? So that's the question, and you can answer it right away.
Yeah, so there the answer would be in terms of so let's say optimal communication between two people, where the message that the one person wants to send across to the other person by means of language is transferred in a way that it really kind of hits the mark, relies on both of those people being responsive to the words that they use in the right way. So, the kind of trivial example would be that if someone would tell me something and tell me something in Japanese, and I don't speak Japanese, that would mean that I have no idea what that person is talking about. However, if I learn Japanese, then basically learning Japanese means becoming responsive to those words in a way that I can make sense of them. Now that's of course learning a completely different language, but you could say that within any given language, you can also have certain subtleties that you can develop. So becoming subtle, becoming sensitive or responsive to the words that someone uses to explain their own situation. This is something that is helpful as well, and this could be done by other ways. But I think the most the best way of doing it is just to have the same kind of experience. So I've never been to Belgrade. So if someone tries to explain to me how beautiful the city is, etc., then you can tell me about some famous square, for instance, but I've never been there, so I wouldn't really know what to do with that linguistic formulation. Now, if I would actually go to Belgrade and experience the city itself, then that changes the way that I've become responsive to descriptions of the city. And in that way, I think you can avoid this restriction that language usually offers. So this is really similar to the answer that I gave to one of the previous questions, right? So being responsive in the right way basically means that yeah, sorry, I think my answer is going in circles now. So I hope the point is okay. So I see a follow-up to that question.
Yeah, there's a follow-up, and there's another question from Lily. So
okay, your answer was great. That's good. Yeah, so I think so the crucial bit here is and again, I mean, so in the negative part of the talk, I was mainly emphasizing how the existing work on experiential knowledge is sort of missing the mark at some points. And one of the ways that it's missing the mark is that it emphasizes both embodiment and narrative, where but in a way that it doesn't offer a solution to how those might be interconnected. Now, I personally think, in line with Merleau-Ponty, that they are very much interconnected. So I've also published on the relation between embodiment and narrative. So my own view is indeed that this embodied, the role of embodiment plays a crucial role in that as well. And then the other question was, are affordances accessible through or dictated by narrative? Is narrative a form of attuned responsiveness? So here too, I mean, this is really like right up my alley in terms of the stuff that I've worked on. So I've written a paper on why narrative is not only this kind of abstract story that you tell, right? So if I create a self-narrative, it's not just something that I tell to people when I'm at a party and someone asks me who I am or something. The narrative that I create is actually concrete. It connects to everyday goals that I have. It connects to the way that I interact with objects in my environment. So I actually use this term, which I call narrative self-programming, which I say that developing your narrative means making yourself responsive to certain affordances rather than others. So yeah, if you're interested in this, I would say read the paper. There's a lot more I can say about this, but I don't want to take up too much time on this.
okay, thank you. We have another question here from one of the guys from the Institute.
Thank you very much for your brilliant presentation. My name is Sergei Shevchenko. I'm a visiting scholar here in the University of Belgrade. And as a philosopher of science, philosopher of medicine, I have a plentitude of questions, but I would like to stop on to the most general questions. The first one is about your general conceptual project. Do you understand you correctly that you are trying first to understand what is experiential knowledge is through the thought experiment, like Mary thought experiment, and then apply it to the specific field, to depth in psychiatry. Or probably you have a more modest and more practical oriented project just to see which healthcare decisions can be altered, can be changed through the inclusion of people with experiential knowledge in their decision-making process. That is the first.
Thanks. So I think it's a bit of both, to be honest. So in the end, I'm most interested in the kind of practical questions, right? So if you have an expert by experience who is part of an interdisciplinary team in healthcare, and let's say the psychologist says we should do A, and the expert by experience says no, we should do B, then how can we resolve those kind of conflicts, given that they rely on completely different knowledge? That's what I find really interesting. Now, the way to target that, I mean, I've been basically trying to approach this from different angles, and one of them is via the more abstract philosophical literature on right, so with Frank Jackson's knowledge argument, the Mary the Scientist idea, for instance. I mean, that original thought experiment is not at all aiming at mental health care, right? It's ontological questions about physicalism. I mean, it couldn't be further away from practical questions. But I think it targets the same kind of intuition, right? Namely that you learn something by experiencing it. And I think that there is value in looking at what philosophers have written about the type of cases that are present in the discussion on physicalism. But I don't think that it'll lead us all the way, so to speak, precisely because it's actually about something else. So what I find really fascinating is that this discussion on physicalism, I mean, I would say it's mostly influenced by this thought experiment of Mary the Scientist, but it's of course about a very specific experience, namely perceiving a color. Now, interestingly, a few years before that, there was a paper by Thomas Nagel, which is also very famous, called "What It's Like to Be a Bat," and I think that is, that should be mandatory reading for everyone who engages in the field of experiential knowledge, because it really tackles not a simple experience like color perception, but a way of being, right? What is it like to be a bat? And he actually also mentions like that his point doesn't only go for what he calls exotic cases like being a bat, but also for more typical cases of what is it like to be blind, for instance. And I think he doesn't talk about mental illness, but I think it would go the same way. Like, what is it like to experience psychosis? What is it like to be depressed? And I think that Nagel makes a lot of very interesting points in that paper, which directly touch upon questions of mental health care. But I mean, as you might know, the paper by Nagel is really a starting point of a discussion. So he doesn't provide that many solutions, so to speak. And again, in the field of experiential knowledge, it's also an ongoing discussion. So there's also not that many solutions present either. But yeah, I do think that there is a lot of value in seeking out these also classical texts. But we have to be careful to not fall in the philosopher's trap and only talk about the kind of abstract stuff, because eventually it has to also be translated to clinical practice and to healthcare, and to see how it works in concrete settings.
Yes, thank you. And I have one more question. It is about clarification, the relation between empathy and responsiveness. You know that empathy is a crucial concept for phenomenology of mental health conditions, and Matthew Radcliffe also dealt with different approach towards empathy, and that the change, that the difference look like the amount of active efforts to for interpretation the particular experience, or it is a separate. There is a separate difference between these two concepts.
So I think this is one of those points where I would have to say that this is still a work in progress. So I favor the more general term of responsiveness because I think it highlights the really basic and, like I said, even trivial element that is at stake here. So empathy is, I think, a little bit a more loaded term and more used in specifically contexts of understanding other people, where I think that responsiveness also has to do with, being responsive to objects in the world, for instance. That being said, I do think that in, fleshing out this idea of responsiveness, it's definitely worthwhile to use the research on empathy, as I've done only a little bit here as well with the work of Matthew Radcliffe. I think there's actually a bunch of interesting fields. I mean, so one thing, for instance, has to do with imagination. So is it possible to imagine what it is like to be depressed or to have autism if you don't have those experiences yourself? I think, again, that really touches on something crucial, namely that many people would have the intuition that you cannot fully grasp it because something is by definition missing then. But that again reinforces the point of, well, what is it that is missing? And is there a way of, even if we cannot fully grasp it, can you sort of approximate that type of experience? So I'm looking into various fields, including kind of social cognition, empathy, phenomenology, but also stuff on imagination and other fields to kind of elucidate this idea of experiential knowledge. So I've been working on this for a couple of years already, but I feel like there is still so much to be done and so much more avenues to be pursued. Yeah, I really like working on this topic, and I hope that I can still do so in the next couple of years.
Thank you. Thank you.
We have another question from one of us here.
Hi, thank you for this interesting lecture. So my question arises from epistemological perspective. So do you think can we connect experiential knowledge with some core ideas of virtual epistemology? In my opinion, it seems that this subjective perspective can be helpful in understanding experience from a first person, from first person. So, do you think that we can connect this, and is this something that can be helpful or not?
Thanks. I'm not entirely sure if I get the question. Could you maybe repeat the central part of the question?
So can we connect the main ideas of virtual epistemology? Should we include this subjective demand in the classical theory of knowledge? And is this something that is helpful in our understanding of experiential knowledge as a concept?
Okay. So actually, this too is something that I'm still kind of contemplating. So I think that it has really been the development in recent years, if you look at epistemology, that there is an increasing emphasis on what people would call the situatedness of knowledge. So this idea that there is a view from nowhere, that you can have fully objective knowledge that is not tainted in any way by the people who obtain that knowledge. that is something that is increasingly being left behind, and I think for good reason. Now, the sort of opposite extreme of that would be to say that it's all relative, and you get this kind of postmodern view that knowledge is always just in the eye of the beholder, so to speak. And I think both of those extremes are best avoided, but where exactly we should end up is, I think, very difficult. I do think that one important remark here is to say that I do think that there is a difference between science, strictly speaking, and clinical practice. So what people mean by objective subjective in science, I don't think we can translate that one-on-one to objective and subjective in clinical practice. Precisely because in clinical practice, we are always, by definition, working with, for instance, testimony by a client, by a patient. And so imagine that you have to decide on a course of treatment. It's almost impossible to objectively say what the best course of treatment is. So objectivity in clinical practice is typically much more a kind of interactive process with different inputs. Some people have a scientific background, some people have a medical background, etc. But there's also the input from the patient or from someone with experiential knowledge. And then in that process, you kind of come to the conclusion of, well, this is the best treatment option, for instance. And that's not objective in a strict scientific sense, but it's the kind of, most useful kind of objectivity that there is, I think, in clinical practice.
Okay, thank you. Do we have any other questions from people here or online? I don't see any questions in the chat. Perhaps I could ask something. This is again more, as all philosophers do, more of a comment than a question, a type of a question. It's clarificatory. So what you're saying in your account is that you try to find, you're looking for attunement between fields of affordances of a person with a certain disorder and a psychiatrist, therapist, or whatever, being the person that tries to understand the other person's different kind of experiences. So you're talking in these terms of skilled intentionality terminology. For example, you have affordances, and every person individually has a certain field of affordances to which it is responsive, and you want to attune the responsiveness of one person to the other. So find a common shared ground experientially, and the real value of someone who has different experience is to show how that experience is stands out from the shared experience between other people. Is that so?
Mm-hmm.
I'm getting it right.
I think that's more or less what I'm saying. I am a bit hesitant though about, as you might actually know, about using the skilled intentionality framework for this.
Mm-hmm.
Because I think that it precisely the stuff that is, so the thing that is probably most at stake in this process of attunement is responsiveness to something like meaning.
Mm-hmm.
So what does taking medication mean for someone? And that, for someone who never had to take medication, that's very difficult to understand. But for people who do have to take medication, that's much more easier. Now, the point is that the skilled intentionality framework is very good at explaining or helping to understand other elements of responsiveness, except for the meaningful part. So I would say that that's actually one of its main weaknesses, and I've published elsewhere about why I think that means that the skill intentionality framework is limited in its application to clinical contexts precisely because it's more useful in precisely those elements that are typically shared, right? So people have roughly the same body with roughly the same skills, roughly the same cultural background, etc. That's all the stuff that people share. But the thing that is different when it comes to people with or without mental illness is usually much more related to things like meaning. And that's precisely what the skill intentionality framework is lacking.
Yes, I recall the paper, yeah, meaningful affordances. But what would the meaning be exactly in this kind of context, experientially? Where is meaning being situated? At what level? Experiential, like pre-reflective, reflective, and so on. How to? What's the difference here? Yeah. Well, what would be the meaning that is different with the patient or with the psychiatrist or so on?
Yeah. So for instance, there has been so let me give two examples. One is a kind of non-pathological context, and I think it's also one of the examples that I use in the paper on meaningful affordances. So let's say that two people get their driver's license, and you ask, what does this mean for you? And one person says, well, now I'm allowed to drive a car, and that means that I can go places. And the other person says, now that I have my driver's license, this means that I can take better care of my family. So the meaning is radically different. And it's also the way that they experience it in terms of emotions. So the practical fact that you're able to drive somewhere is, for most people, not very strongly associated with any kind of emotion. But being able to provide for your family is a very emotional affair. So in the paper, I cite a study on emotional experiences, and I use this example that is actually taken from that study to show that the meaning of one affordance, in this case, the driver's license, varies significantly across different people. In the case of mental health care, I would say something along the lines of like the example I just gave about medication. So what does medication mean? So a lot of people that I've talked to about this issue is that the step from taking medication for the first time is an enormously big step, because it means that they have to acknowledge that they are now a person who has to take medication. And I mean, again, this is interesting, because people who are not sort of familiar with this, they will say, well, what's bad about that? Whereas people who have experienced this step of having to take medication know that it's really a big step, because it affects all of your identity and your self-image. It really creates, you have to sort of rewrite the idea of who you are, because you apparently need like how do you say that? Like a sort of biological addition to your own biological system in order to function appropriately. So the kind of meaning that this little pill that you're supposed to take has is really enormous. And I mean, on a sort of very simple level, what does a pill of medication afford? Well, it affords picking up, and it affords putting in your mouth. But obviously, that's not at all what is at stake. What it affords is a radical disruption of your identity, and that is the way that they experience it.
Okay, that's an excellent answer. I wanted to just discuss a bit this kind of example of autism, because you gave several examples of depression, schizophrenia, and so on, psychosis, of changing of experiences, and how one comes to be driven to examine their changes in their field of affordances, in their the whole change of responsiveness to certain affordances. But perhaps in the case of something like autism, this kind of disorder, which is a lifelong disorder. You have it from birth to death, and there's no specific change that comes into one's life, and now you become autistic or something like that. So I'm not saying that that is kind of a problematic for this whole framework, but what is the difference between that and something like depression? You have like a normal state and then you become depressed or something different. How does one who is autistic become an expert by experience because other people tell them that they're autistic, something like that, because there is this kind of a social element to someone becoming an expert by experience, whereas in other disorders, it is the person themselves that sees the change and kind of examines it in self-reference and so on.
Mm-hmm. So I think that it's important to stress that this idea of responsiveness to some extent is not normative at all, right? So responsiveness just kind of results from your experience. Now, this idea of attunement is normative. So it suggests that there is a good way, an optimal way of changing your responsiveness, for instance. And I think you're right to point out that there is a difference here between more episodic forms of illness, which could be psychosis, for instance, or more chronic or developmental things like autism, or this also goes for certain somatic illnesses, for instance. And one of the differences seems to be that if you have a certain like sudden onset of depression, then that means that you have kind of a baseline that you can compare yourself to, right? So you have yourself before the depression and you have yourself after the depression, so to speak. And that baseline can be something that you use in, contemplating your own responsiveness and in this process of attunement. And as you say, in the case of autism, that doesn't really seem to work because you already have it. So I think that to some extent, this isn't necessarily a problem. I think that it may be a case where it even actually goes the other way around, right? So a lot of people with autism, they find out that they have autism because they find out that other people apparently experience the world differently from them, right? So they can be surprised that other people are fine with sort of sudden flexible changes, whereas they find it very difficult. So it's almost like a radical empathy in the other direction, so to speak, right? So neurotypical people trying to understand neurodiverse people, that's one step, but the other way around is again also requires work, so to speak. I think so. What I said about the normativity of this process of attunement, I think the difficulty is that it's very problematic to speak about this in very general terms. So what is good attunement, or how should this process work? Well, that kind of depends on like what you're doing, right? So I gave the example of attuning to my 2-year-old daughter, for instance. That's relatively concrete. We can discuss like how that attunement should proceed and what you could do in facilitating that. But if you talk about attunement in the case of autism, I think it really has to do with what it is that you're trying to do. So I think it's different if you ask someone with lived experience in autism to assist someone else who is recovering from autism, for instance, or who is going through some difficult moments. That will be different than asking that person to, provide input for like policy making, which is a much more abstract thing that they would have to contribute to, and which arguably requires less attunement, for instance. I'm not entirely sure if I really answered the core of your question, but feel free to follow up on that.
No, that's okay. It wasn't much of a question, just to discuss this kind of a different case within the framework. So, but yes, it's a good answer. Thank you. Do we have any more questions? I don't see any. So thank you again for accepting the invitation for giving the lecture at our seminar. Hopefully we'll see you again here. Hopefully all the questions were useful for you and your work later on. So
Definitely. So thanks for having me, and thanks for all the wonderful questions.
thank you. See you.